Good evening and welcome to the ninth presentation of the basic modules in infectious disease organized by the Infectious Disease Forum of the Federation of Clinical Pharmacists of India. Hi everyone, I am Dr. Arya S. Kumar, ID Forum member of FCPA. I am moderating the session for today. Before we begin, I would like to give you some instructions. Firstly, if you have any questions throughout the webinar, please write them in the chat session. Your questions will be discussed during the Q&A session at the end. Secondly, the feedback forms will be available below the video thumbnail of the FCPA website towards the end of the session. Next, the certificate will be given within 10 days of submitting the feedback forms. The slides of the presentation can be downloaded from the website, and login is mandatory to download the file. So we would like to hear from you if you are facing any issues. So feel free to contact us for any assistance through the email ID provided in the website. I hope the instructions are clear. So today's topic is pharmacokinetics and pharmacodynamics of antifungals, and our speaker is Dr. Alia Salim. She's a clinical pharmacist at Apollo Cancer Center in Chennai with a deep commitment to patient care and a wealth of experience in oncology and infectious disease. She stands as a pillar of expertise in her field. So, Dr. Alia Salim is an active ID Forum member of FCPA. Currently, she is involved in the crucial initiatives of digitalizing antimicrobial stewardship within her hospital. But before we start the session, I would like to give you about some information about the upcoming events. So join us to celebrate the first anniversary of FCPA on World Pharmacist Day. FCPA, in collaboration with BPS, Board of Pharmacy Specialties, is organizing a virtual panel discussion on the topic, Everything You Need to Know About BPS Pharmacist Certification on 25th September from Indian Standard Time, 7 p.m. to 8 p.m. You can scan the QR code to attend the virtual event, and the registration is free, and the expert panelists include Associate Director, Executive Director of BPS, Mohammed Hisham, Ajmal, Anita, and Sunny, Grace Mary John. So all the queries that is related to BPS certification will be addressed during this panel discussion, and you can mail your questions to FCPA mail ID, fcpaofficials@gmail.com. Second is the CP Conclave 2023 to be held on 15 to 16th November. It is organized by Amrita School of Pharmacy in collaboration with FCPA. And registration is on a first-come, first-served basis. You can enroll now and secure your seat for the event. The theme for CP Conclave 2023 is Engaging Students in Infectious Disease and Antimicrobial Stewardship. You can submit your abstract on case reports, reviews, and original research for poster presentation. You can participate in a fun-filled ID quiz, and you can also take part in the antimicrobial stewardship theme cartoon drawing competition. So you don't miss the opportunity to interact, network, collaborate, and learn from the experts, and prepare to spend 2 days of non-stop learning from clinical pharmacist, physician, microbiologist, and academician. So register soon. You can download the brochure from FCPL official LinkedIn account, and the registration links are available in the brochure, and you can also submit your abstract and the link provided. Third is the CP Submit 2023, which is to be held in today and organized by Indian Pharmaceutical Association's Students Forum in collaboration with FCPA on 25th and 26th of November. Fourth is the ID Congress 2024, which will be held in ICRA Hospital, Calicut, in collaboration with FCPA from 19th to 21st of January 2024. And the theme of the event is Infectious Disease and Antimicrobial Stewardship in Critical Care. So block your dates for the second ID Congress. There will be e-poster presentation. So be ready to present your research. And this event need live in-person registration. For more you can follow our social media for all the updates. So without any further ado, over to you, Dr. Ali.
I'll do it. Thank you for the welcome, Arya. Today's topic is antifungal pharmacokinetics and dynamics. I know pharmacokinetics, dynamics, mechanism of action is not something liked by us, especially clinical pharmacists or pharmacists, but it is that bitter pill we have to swallow to understand what exactly is happening to the patient or the antifungal therapy. So please be patient with me for the next 1 hour. So before we begin, I just want to inform that I do not have any relevant financial relationship with any commercial interest. So learning objectives include pharmacokinetics, dynamics, mechanism of actions, clinical outcomes, antifungal therapy in renal dysfunction, hepatic dysfunction, and extracorporeal circuits, what to do, then what happens if we combine the antifungals, etc. So fungal infections is also known as mycosis. It is a disease caused by fungi. So any type of fungus can cause any part of our body. Fungus infection can be superficial, it can be subcutaneous, or it can be systemic too. Fungal infections are caused by various fungi. It can affect any part of our body. It can affect our lungs, it can affect our skin, it can affect our brain. Even our nails are not safe from fungal infections. And it differs from bacterial infection by fungal infections are slow, chronic, and it takes a lot of time to cure, unlike bacterial infections. So antifungal is an agent, by definition, it is an agent that selectively eliminates the fungal pathogens from a host with minimum toxicity. So pharmacokinetics is a science. So coming to the pharmacokinetics, it is a science that analyzes how the human body interacts with a drug. Pharmacokinetics examines the absorption, distribution, elimination, metabolism of our body. Coming to our dynamics, pharmacodynamics, it is a science that studies the biochemical and physiological effects of a drug, and it is organ specific. It includes mechanism of action, what are the side effects. It also goes to the cellular effects. So another way of describing is the difference between both pharmacodynamics and kinetics is that pharmacokinetics is what the body does to the drug, and pharmacodynamics is what the drug does to the body. So this is the classification of antifungal agents. I've tried to include all, starting with the antibiotic antifungals, is divided into polyenes and heterocyclines. Under polyenes is the most important, most initial drug, that is the amphotericin B. Again, it has various formulations. Then we have nystatin, hampsin, natamycin. Under heterocycline benzofuran, we have griseofulvin. Then next class of drug is antimetabolite, which has flyfluorocystisin. Then next is the azole antifungals, which is again divided into triazoles and imidazoles. Triazole contains our usual fluconazole, itraconazole, posa, voriconazole, etc. Imidazole is again further divided into topical and systemic. Topical contains clotrimazole, iconazole, miconazole, etc. And ketoconazole comes under the systemic antifungals, imidazoles. Then we have allylamines, which are the terbinafine, echinocandins, which is one of the most important and recent antifungals. We have the 3 caspofungin, micafungin, and anidulafungin. Then other topical antifungal include tonlaftate, sodium thiosulfate, olamine, butanafin, so etc. So fungi is a eukaryote organism that have a cell wall made up of chitin, whereas bacteria has a cell wall that is made up of peptidoglycan. This chitin in the cell wall of the fungus is what makes it very complicated for the therapy. Coming to the fungal infections, so we have different classes of fungal infections. Each classification has its own unique mechanism of action. Each classification targets unique spectrum of activities. For example, the most commonly used ones are polyenes, azoles, and echinocandins. But when we see the mechanism of action of each of these classifications, we can understand that mechanism of action is completely different. For example, azoles, they inhibit the ergosterol synthesis. Echinocandins, they target the beta D glucans. Then allylamines, they interrupt the synthesis of DNA in the fungi. Then griseofulvin, they just stops the mitosis and prevents the formation. Coming to the clinical applications, why do we have to study pharmacokinetics? Why do we have to go deep into the mechanism of action? So clinically, what happens is that determining the dosage and frequency of administration. What dose, what is the infection of the patient, what is the duration of therapy that needs to be given can only be determined if we know the pharmacokinetics and dynamics of the drug. Next, in vitro susceptibility breakpoints. It just means at what dose, what duration, what infection, what patient does this work is determined by pharmacodynamics of the study. Then selection of appropriate antifungals. For what works for the eye may not works for our brain. What works for a CNS may not work for our lungs. To understand what works where, the clinical parameters, pharmacokinetics plays a very important role in it. Then, of course, improve the clinical outcome, reduce the risk of resistance, etc. Then next comes our drug development. Of course, optimizing dosing regimens, determining susceptibility breakpoints, limiting the toxicity. As we all know, antifungals has a lot of toxicity. So to reduce that, we need to have a proper understanding of the PKPD of each drugs. So, and pharmacokinetics are influenced by factors like administrations, by patient characteristics and drug interaction, the absorption metabolism. It can vary from patient to patient, drug to drug, etc. So some antifungal agents like fluconazole has a higher bioavailability when given orally, but amphotericin B and all requires an IV administration because of its poor oral absorption. Then we have additional some antifungal agents may be metabolized by liver enzymes, which can lead to drug interaction with other medications. As we all know, when we talk about drug interaction, azole classes and all plays a very important role. Fluconazole and has a lot of interactions. So we have to keep that also in mind. Next is understanding the pharmacokinetics of antifungal agent is crucial for optimizing treatment outcome and minimizing the toxicity. So pharmacodynamics. Now we are entering the pharmacodynamics portion of the section. So pharmacodynamics of antifungal agents refers to the relationship between concentration of the drug and effect on the fungus. At what concentration does it cause an effect on what pathogen is determined by pharmacodynamics. So a lot of factors can interfere with this, like what dosage, what is the duration, etc. Then antifungal pharmacodynamics is a complex topic that requires an in-depth understanding of both fungus and the drug being used. Next is the antifungal susceptibility testing. It is reliability to produce MIC, maximum inhibitory concentration values that may be used to guide a patient therapy and inform epidemiology and track rates of antifungal resistance. So minimum inhibitory concentration. It is the lowest concentration a drug needs to exhibit the growth inhibits the growth of fungus. Means what is the minimum dose required to stop the growth of fungus? That is minimum inhibitory concentration. So in order for treatment to be effective, the drug concentration should remain above the MIC for a certain period of time. Then comes the time. So this time, that is the time above the minimum inhibitory concentration, is very critical in determining the treatment efficacy. So MIC, it is defined in MIC is minimum inhibitory concentration. So it defines in vitro susceptibility or resistance of specific antifungal agents. So it has a very significant effect on the choices of therapeutics. So even when we see the susceptibility and resistant chapter, the MIC is what matters the most. So when we decide which antifungal needs to be used, we choose the ones which is closest to the MIC and breakpoint, susceptibility breakpoint of the pathogens. It is usually microgram per ml or mg per ml is what we use in MIC. And there are standardized reference for MIC. You can go in ucas.org, clsi.org. So you can find the standard values of MIC in this. So this is the targets of systemic antifungals. As you can see, each antifungal has different sites of action. For example, the azoles, they target the ergosterol synthesis. Then we have the polyenes, which contains amphotericin B, which inhibits the ergosterol. Then we have echinocandins, which stops the beta-D glucan synthesis. Then fluoropyrimidines, which stops the DNA RNA synthesis, etc. So what it means is that depending on the fungal infection, we can change based on that. So Cmax refers to the maximum concentration of the drug that needs to be given to attain most effective therapy of the patient. Tmax refers to time at which maximum concentration. So you see that Cmax happening in a patient. So at what time it happens, that is Tmax. T half is half-life. It is the time taken to remove half of the drug from our system. It can vary from drug to drug and patient to patient. AUC is the area under the curve. It is a total exposure of the body to the drug at a particular time is area under the curve. So different antifungals has different properties. Some are concentration dependent killing. That can be used, that value is determined by Cmax by MIC. Then some drugs are time dependent, duration. Based on duration only, you can determine the therapy of it. So those that we'll see area under the curve with MIC. Then some drugs will need frequent administrations like flucytosine. We need to give continuous, like 4 times a day, 3 times a day to attain minimum inhibitory concentration. And PAFE is a value we regularly use in antifungal PKPD. It is known as a post-antifungal effect. Even after the drug is being eliminated, the antifungal will have some effect in our body. So that time, it can be 2 to 3 hours or it can be 10 hours. So what is the post-antifungal effect in our body is known as PAFE. So coming to the patients in renal impairment, dose reduction is guided by the glomerular filtration rate. That is what determines whether we need to do a dose reduction, whether the drug is contraindicated or we can just use the standard dosing is determined by glomerular filtration rate. For example, amphotericin B is completely contraindicated in patients with reversible renal impairment. Again, that is deoxycholate amphotericin B, not liposomal or emulsion form. So we don't need any dose adjustment in liposomal amphotericin B, but there is always a chance of nephrotoxicity. So it's better to avoid in patients with renal impairment. Next, flucytosine and fluconazole are mainly eliminated via the kidneys. Echinocandins are broad spectrum and azoles. We don't need to adjust any dose in echinocandins. And in azoles, like voriconazole, posaconazole, and isoconazole, we can give a standard dose even in renal failure. But there is a particle called SBECD, sulfobutyl ether cyclodextrin. That is a solvent that is used in many of the antifungals or most of the drugs for its It is used mainly for its storage and so this accumulation also is something what we need to not take in consider, not just the drug but also the solvent, as if this drug is, if this solvent SBECD cyclodextrin is available, we have to avoid intravenous voriconazole and posaconazole, etc. Next is the what do we do in case of liver impaired liver functions. So again, most of the drugs are also metabolized in the hepatic system. So maintenance dose of voriconazole should be reduced, and in patients, it should be avoided in patients with liver cirrhosis. And we can reduce the dose of caspofungin in liver cirrhosis, but again, there could be a chance of underdosing also. And anidolafungin, you can apply it in standard dose. It is very safe in the liver. Micafungin is something that should be completely avoided in liver impairment. We don't need to do any drug dose adjustment in posaconazole and isoconazole in liver adjustments. And again, we have to do therapeutic drug monitoring to know the toxic effects of the antifungals and how it should be performed. There is something known as child pulse scale. It is designed to predict mortality in liver cirrhosis patients. So there is 3 categories: A, B, and C. Category A means good hepatic function. Category B means moderate hepatic function, and category C means advanced hepatic function. So based on this child pulse scale, we'll decide whether the drug could be given in patients with liver issues or not. Antifungal treatment of patients on extracorporeal systems. Extracorporeal is dialysis, hemodialysis, then CRRT, continuous renal replacement therapy. So what do we do in patients having extracorporeal circuits? So in case of intermittent hemodialysis, we can the dose of 5-flucystine should be reduced to 37.5 mg per kg after hemodialysis. Fluconazole should be applied at a maintenance dose of 100 to 200 mg after hemodialysis. And in 5-flucystine, treatment during CRRT should be between 2.5 gram every 72 hours and 2.5 gram twice daily. So again, therapeutic drug monitoring is very advised in case of patients with dialysis or CRRT. We can give an enhanced dose of itraconazole during CRRT as the clearance is very high in this case. Then standard dose of voriconazole, echinocandins, and posaconazole is appropriate in CRRT patients. Then in patients on intermittent dialysis, we should avoid the drugs that contains SBECD, cyclodextrins, in the formulations. So time for the first question. Which of the following echinocandins should be avoided completely in patients with hepatic dysfunctions? Your options are A, caspofungin, B, micafungin, and C, anidolafungin. You can answer in the comment box below and we'll get back to it at the end of the session. Next, we'll move on to the combination therapy. Means combining 2 or more antifungals for the patient. So why are we using it? To maximize the antifungal effects by attacking the same or different targets in fungal cells and making use of synergetic effect. That is why we are using combinations. For example, as we discussed before, different antifungals have different effects on the fungal cell wall. Some can some can attack cell wall, some can go for ergosterol, some can go for beta-D-glucan. So the combination will give us an increased an increased effect, and it can cause a synergetic. Again, it has its own advantages and disadvantages. So some of the advantages are it is broad spectrum of coverage. Each antifungals has different spectrum of coverages. So when you combine two, the spectrum increases. Then synergistic effect, two drugs working together is always a good idea for especially in critically ill patients or immunocompromised patients, etc. And lesser toxicity if lower doses are possible, and resistance can be reduced. For example, if we give one drug for 10 days and two drugs for 5 days, that additional resistance can be reduced in combination antifungals. And then coming to the disadvantages, cost is something we should always keep in mind, especially in case of antifungals. Cost benefit analysis plays a very big role in this. Antifungals are very costly. Some of the especially our echinocandins and all. So combining them can again increase the cost of the therapy. So again, combination therapy depends on the financial background and financial affordability of the patient. So this is one of the main disadvantages. So it can also increase toxicity. Combined effect at greater doses can enhance toxicity. So combination of antifungal therapy, there are many methods to determine the efficacy of each. So we have the checkerboard method where two individual drugs are separately tested for efficacy, and they are tested in combination, and we'll understand the difference whether they works better in combination or they works better individually. Then we have the time kill method where it is exposed to a drug and we'll see how long does the resistance or the susceptibility goes on. So that is a time kill method. Epsilometer test and the response surface modeling method. These are also few of the tests that is used for combinations. Response surface modeling is the pathogen will be placed near the antifungals and they'll not grow if they are susceptible to the antifungal. Suppose one drug is susceptible to this organism, so this organism will be placed next to that drug, and if it is susceptible, there won't be any growth. If it is not resistant, there will be growth. That is the response surface modeling. So at lower doses, synergism is observed, and at higher doses, antagonism is observed. So we have to, so for example, combination therapy with caspofungin, with voriconazole or aspergillus, it improves the therapy efficacy. Like caspofungin with voriconazole or caspofungin with amphotericin works great. But there is interaction between amphotericin B and fluconazole, which are concentration dependent. Means at lower doses, they works in synergetic effect, but at higher doses, they can interact with each other. Again, this is a chart to determine CD is concentration dependent. As you can see, polyenes and echinocandins are concentration dependent, whereas triazole and flucytosine is time dependent killing. Means depending on the concentration is the rate of fungicidal or fungistatic activities, while in triazole and flucytosine, there is time, duration of therapy matters. Then post antifungal effect is not there in flucytosine, except that all other drugs has post antifungal effect. So coming to the structure of a fungal cell wall, most of the fungal cell wall is made up of nanoproteins. Then we have beta-D-glucans, there's a presence of chitin and plasma membrane and ergosterol. So ergosterol is a component, most important component of a fungal cell wall. Most of the antifungal targets ergosterol synthesis. For example, amphotericin B, it attacks the ergosterol and it causes ionic leakage, and it causes the cell to rupture and die. But the disadvantage with ergosterol is that our mammalian cell has a ergosterol mimicking component, like for ergosterol mimicking component, cholesterol. So it is non-selective attack. So it, along with ergosterol, the drug amphotericin B attacks our mammalian cell cholesterol also. So this is why there is a higher nephrotoxicity in amphotericin B. Nystatin also attacks the ergosterol, but it does not. But the difference between amphotericin B and nystatin is that the nephrotoxicity is higher in nystatin, hence it is not preferred internally, or it doesn't even cross the skin barrier. So nystatin is now limited to superficial infections on our skin. So ergosterol synthesis uses something called as squalene, which converts itself to lanosterol in the presence of squalene epoxidase. So this lanosterol then further converts itself into ergosterol with the help of CYP450 14A demethylase. So this drugs like allylamines, they target squalene epoxidase. So there is no conversion of squalene to lanosterol, and this inhibits the fungal cell growth. Azoles, on the other hand, they targets the CYP450 14A demethylase, and that will stop the conversion of lanosterol to ergosterol, and this causes the inhibition of fungal cell wall. So coming to the pharmacokinetics and pharmacodynamic considerations. There's a quote by John Locke saying, did we but know the mechanical affections of particles of rhubarb, hemlock, opium, and on a man, we should be able to tell beforehand that rhubarb is purge, hemlock kills, and opium makes a man sleep. It just means that if we knew furtherhand how something works, we can use it or we can avoid it based on our needs. So antifungals are again divided into fungistatic and fungicidals. Our azoles comes under fungistatic. Echinocandins are fungistatic if acting on Aspergillus. And in fungistatic, we see the area under the curve and MIC values. In fungicidals, amphotericin B, then echinocandins on Candida species. Fungicidal activities is again concentration dependent. So we see this maximum concentration with MIC value. So coming to our first class, like polyenes, mainly like amphotericin B. There are three types of amphotericin B. We have the conventional, which is the initial drug. Then we have the liposomal amphotericin B, and then we have the latest formulation, that is the emulsion. All these things drugs are same, but the formulation is being made different because of its high nephrotoxic activity. Conventional has the highest nephrotoxic activity. Liposomal is in between lipid layers. So compared to conventional, the nephrotoxic is less, and emulsions again lesser. So yeah, liposomal amphotericin B has improved toxicity compared to deoxycholate. That is, deoxycholate is a conventional amphotericin B. So the difference is liposomal activity has also CNS penetration. So it is used in CNS infection like cryptococcal meningitis and all. Liposomal amphotericin B also acts against protozoal parasites, Leishmania species, and but the inhibition is non-selective, as our mammalian cell wall cholesterol is also affected. So renal toxicity is something that we discuss in more. Renal toxicity and acute infusion-related infections are most common in amphotericin B. Infusion-related adverse effects means the moment the infusion starts, within minutes you can see some changes. It can be inflammation, it can be some redness or fever or shivering. All this comes under infusion-related ADRs. So this is most common in amphotericin. Again, nephrotoxicity is because there is a vasoconstriction of the renal arterioles of the kidneys, and this reduces the renal blood flow, which leads to accumulation of the drug particles. That is how there is a renal toxicity and nephrotoxicity that happens. So this is the chart for amphotericin B susceptibility and resistance. In case of susceptibility, the glucan cell wall will be thinner compared to resistant molecules. If the organism is resistant, they will be having a thicker layer of glucan cell wall. This is the liposomal amphotericin B. As you can see, amphotericin molecules are in between the lipid layer. So this is how it enters the cell wall and reduces the nephrotoxicity. So clearance is approximately 1 to 2 liters, which is lesser than most of the antifungals. So liposomal has longer half-life, and total plasma concentration is also higher in liposomal compared to deoxycholate. So it is concentration dependent again. Post-antifungal effect is about 12 hours, and liposomal is safer in pathogens like Aspergillus, cryptococcal meningitis, invasive candidiasis, and mucormycosis. In mucormycosis, it is a gold standard. It is the first line of therapy in case if the patient does not have any renal impairment. So lesser urinary and fecal clearance of liposomal compared to conventional. This is the pharmacokinetic differences in amphotericin B deoxycholate and liposomal amphotericin. As you can see, maximum concentration is higher in liposomal, and area under the curve is also higher. In case of renal impairment, we don't have to do any dose adjustment in liposomal, but in case of amphotericin B conventional, it is completely contraindicated. Coming to the next class, it's flucytosine. It is initially synthesized as a cancer drug. Then later, due to its antifungal properties, used as an antifungal. So it disrupts the DNA and protein synthesis, inhibiting the fungal cell growth. It works in a synergetic effect in amphotericin. With amphotericin B, it has a synergetic effect as they increase the cell membrane. So the duration of the therapy can be reduced. So high absorption, and I can say 80 to 90%. It also penetrates into our eye, CNS, urine, kidney excretion is more than 90%. But the reason we don't use is the emerging resistance to the flucytosine is one of the reasons why flucytosine isn't used that much. It also has a narrow therapeutic index, so we have to go on giving frequent doses, I think 4 times a day to keep an MIC breakpoint. Even when the drug dosage comes below the MIC, it can cause the organism to regrowth. So flucytosine is not preferred most of these days. So as you can see, it is given 4 times a day, 25 to 37 mg per kg. In case of renal impairment, we have to have a dose reduction guided by glomerular filtrations. Strong therapeutic drug monitoring should be done to eliminate toxicity. So second question, which is the first line of treatment in case of mucormycosis? Options are A, fluconazole, B, amphotericin B, C, caspofungin, and D, isavuconazole. You can again answer it in the comment box. We'll get back to it. Next is our triazole class. It is the class of drug with the highest studies conducted. So it has the effect is higher because of its combination of concentration independent action. So we don't have to do any dose adjustment in triazoles, and it also has a prolonged post antifungal effect. So this is why the higher efficacy of triazoles. So first drug in that is fluconazole. It is approved for vaginal candidiasis, orophageal, UTIs, peritonitis, systemic inflammation, cryptococcal meningitis, etc. It also has a prophylaxis, works great in patients undergoing bone marrow transplant, receiving chemotherapy or radiation therapy. So in case of fluconazole, the half-life is around 30 hours. Already that is more. If the patient is having any renal impairment, and if the creatinine clearance is lesser, we if it is less than 50%, 15 ml per minute, we have to reduce the dose of fluconazole up to 50%. That is because again the 30 hours again prolongs it, so that half-life increases. It is found in many body fluids, especially cerebrospinal fluids and dialysis fluids. So it helps in the systemic antifungal infections like coccoidal meningitis and fungal peritonitis. So pharmacokinetics is linear. We can give up to 50 to 800 mg per kg. Where there is a wider tissue distribution. Most of our tissues are covered. We need a loading dose to achieve steady state. Area under the curve, that is the total drug exposure, is the drug what we administer. For example, if we administer 800 mg, the area under the curve is 800. Then patients undergoing CVVH, that is veno-venous hemodialysis. So in such patients, they have the higher clearance. So we need to give a higher doses of fluconazole, and it has an excellent bioavailability. So IV dose is equal to oral dose. This is a pharmacokinetics chart. It comes under pregnancy category C for single dose, and D for in combination and in other regimens. Next is voriconazole. It is a broad spectrum antifungal. It inhibits P450 14A demethylase. So it is a first available second generation triazole. For it is approved for Aspergillus, Candida, Cryptococcus neoformans, etc. It is also approved for treatment of candidemia in patients who are not neutropenic. For esophageal and disseminated candidiasis as first-line therapy for mycosis, which is caused by Pseudosporium and Fusarium species. So voriconazole are rapidly absorbed, and within 2 hours, you can have a bioavailability of more than 90%. It is the dose-dependent pharmacokinetics. So it has voriconazole is a time-dependent fungistatic activity. Then toxicity can happen in prolonged therapy, like phototoxicity, hallucinations, hyponatremia, etc. This is the pharmacokinetic considerations of voriconazole. It comes under category D of pregnancy. Usual dose is 200 mg twice daily. Hepatic elimination, and 1 to 2 hours of maximum house to reach the maximum temperature. Time. So next azole is posaconazole. It is a systemic triazole. It is a drug that is derived from itraconazole. So posaconazole is licensed for patients receiving remission induction chemotherapy, and if they are expected to have a prolonged therapy of if so such patients, posaconazole prophylaxis has been given. And next comes the HSCT recipients who are undergoing high dose immunosuppressive therapy for graft versus host disease. So to prevent any fungal infection, posaconazole prophylaxis can be given. Next, it is also for treatment of oropharyngeal candidiasis for patients who are intolerant to first line of therapy, and also as a salvage therapy for rare pathogens such as fusariosis, chromboblastomycosis, coccidioidomycosis, mycosis, etc. So coming to the pharmacokinetic parameter, it has a high inter-individual variability, means it can vary from patient to patient and drug to drug. So up to 53% there is inter-individual variability. So there can be the absorption can differ from the food what we take, or gastric emptying, or how much posaconazole doses be given. All this can affect the absorption of posaconazole. For example, in immunocompromised patient, if you give PPIs or metoclopramides, or if they have a recurrent diarrhea or mucositis, this reduces the bioavailability. But if we give nutritional supplements, it can increase the bioavailability. It also has a wider distribution. As you can see, it reaches almost every part of our body. Then coming to the elimination and biotransformation, fecal excretion of posaconazole, that is 77% of the drug is excreted through fecal. And out of that 77%, 66% is unchanged. There is 13% urine elimination. So posaconazole plasma concentration may increase or decrease if we give glycoprotein inhibitors. Inhibitors can increase the plasma concentration, while the inducers like rifampicin can reduce the plasma concentration. Now coming to aspergillus resistance. Aspergillus resistance can happen even after single exposure to azoles. So azole resistance is very common in patients who had undergone aspergillus treatment. But in this cases, posaconazole is preferred as the isolates has MICs that are closest to the resistance breakpoint. So even though if it is resistant, we can use posaconazole at a higher concentration. Next comes the last azole. It is a recently developed azole. It is approved by FDA and European Medical. It has an amazing pharmacokinetics. It is a water-soluble drug. That is, it has a prodrug called isoconazone sulfate. Isoconazonium sulfate. That is 372 mg. For example, even though if we give as 200 mg, some physicians can write it as isoconazole 372 mg. That doesn't mean that we have to double the dose, or we have to like do the dose calculation of 2 vials and give isoconazole. It just means that 200 mg is equal to 372 mg of isoconazonium sulfate. So it is highly water soluble. So we don't need any cyclodextrin or any extra solvent, which can cause nephrotoxicity. The pharmacokinetics is linear and clearance is low. It has a very broader spectrum coverage equivalent to voriconazole, and it also has activity against mucormycosis. In case of patients in mucormycosis, if amphotericin B doesn't work, or if the patient has renal impairment or reduced creatinine clearance, isoconazole is the next drug of choice. But again, in this case, cost matters because it is very costly drug. That's why most of the physicians hesitate to start isoconazole because of its cost efficacy. So pharmacokinetics is linear and it is not removed in hemodialysis. So we don't have to adjust the dose in patients with hemodialysis. Again, you don't have to do any dose adjustments for isoconazole in patients with renal impairment. And there is no changes in absorption because we took extra dose, or if the patient's diet can affect it, or even the gastric pH does not affect the absorption of isoconazole. Coming to invasive aspergillosis and mucormycosis. So isoconazole is non-inferior to voriconazole and it is FDA and EMA approved for invasive aspergillosis and mucormycosis. It is very well tolerated and it is very safe. The studies are still going on, but so far so good. Even compared to voriconazole, its side effects and ADAs are very less. So next class of drug is echinocandins. Echinocandins works as a milestone for the antifungal treatment. It is specially designed for once daily dosing. It is not metabolized in cytochrome P450, so it is well tolerated due to less toxicity. There is no disposition or accumulation in tissue or body fluids. It has a better relationship with dosage, concentration, and efficacy. It is mainly used for invasive fungal infections in immunocompromised patients who are critically ill. So first drug is caspofungin. It, as you can see, it do not attacks ergosterol or the cell wall. It directly goes and inhibits beta D glucan. That's why it is very safe in patients with renal issues. So it is licensed for adult, not in children. It is developed as parenteral agent, and there is no oral options for caspofungin as its molecular size is higher and the bioavailability is very less. So it is licensed against Candida species and Aspergillus species. The usual dose is 70 mg loading dose followed by 50 mg per day. So we'll get a 1 microgram per ml of therapy throughout the treatment. So half-life is about 9 to 10 hours. Drug clearance is at 10 to 12 ml per minute. Dose-dependent drug accumulation. Then it is administered at a constant rate in IV infusion. So coming to the high dose concentration versus, there is always a debate going on about high dose caspofungin and the standard dose, that is a 70 mg per day dosing. So the usual dose is 70 mg per day, but there was a study that conducted which showed that even 150 mg per day in critical patients can the differences were not significant. There was some percentage difference, but it didn't make any big difference. There was in 150 mg patients, the Candida species were positive in the culture report, a little more than 70/50 mg. Again, drug-related areas, signs and symptoms, and evidence of new lesions were evaluated, and the differences were insignificant. So, but still, in critical patients with IFI, we can give up to 2 mg per kg, especially in obese patients. 2 mg per kg can be given per day. Next is micafungin. It is a selective inhibitor of beta D glucan. It is a first line option for candidiasis, linear dose proportional pharmacokinetics. High dose is less frequent dosing. That means if you're giving a higher dose, reduce the frequency. Suppose if you're giving 200 mg of micafungin, give it every 48 hours because it has a very high toxicity profile and a very good post antifungal effect. So we don't need to do any dose adjustment of micafungin and hepatic dysfunction. Yeah. So micafungin higher doses is given for patients in in children. The higher doses of micafungin is given because of its higher clearance. For example, in premature neonates, the clearance is 40 to 80 ml per hour per kg, and in children more than 4 months, the clearance is 20 ml per hour per kg. So we have to give a dose of 4 to 10 mg per kg in premature neonates, and we have to give a dose of 2 to 4 mg per kg in children more than 4 months. The bladder distribution is very less, that is less than 1%. So we can't give in case of any urinary infection, but you can give it for candiduria. It can be due to the excellent penetration of micafungin in kidneys. So coming to the elimination of it, systemic clearance after infusion is about 12 ml per hour, and it has a half-life of 14 to 15 hours, and it is independent of dose. Whatever dose you give, the half-life remains the same. In case of critically ill patients, exposures are much lower than exposure found in healthy volunteers. So these patients, you can give them a higher dose up to 200 mg. Coming to burn patients, so there is patients with thermal injuries shows lower concentration of micafungin. Even such patients, you can give 200 to 300 mg of the drug compared to healthy volunteers. So in hematological patients, there is a different pharmacokinetics of micafungin. So volume of distributions remains the same, but they have a higher clearance of 13.6 ml per hour per kg. Next is the newest class of echinocandins, that is Anidula fungin, which are recently approved by the FDA. It is licensed for esophageal candidiasis, candidemia, deep tissue candidiasis, etc. It has a potent in vitro fungicidal activity, effective against species of candida that is intrinsically resistant to amphotericin B or other echinocandins. So if we combine it with amphotericin B, it has an additive effect, and it is also synergic with itraconazole or voriconazole in treatment of aspergillus. So, okay, anidal fungin is not eliminated from our body through renal or hepatic excretion. It is slowly degraded in the plasma. So even after the therapy, even if you give a loading dose, even if the therapy is stopped, there will be some drug remaining in our body up to 4 to 5 days. Anidula fungin, again, it's only administered parenterally, and more than 80% is protein bound. As said, even after 4 days, there will be a degraded products in our body. The half-life is 24 hours, hence once daily is advised. In pediatric patients, clearance rate is similar, so there is no need to adjust the dose of anidula fungin. So next question 3. Echinocandins are the least nephrotoxic agent. And so is it true or false? We'll get back to it later. So this is the section where there is a connection between our human ancestry and genetic predisposition to fungal infections. So apart from all these parameters, our genetics, our the mutations that our body has undergone plays a very important role in fungal infections. For example, there can be polymorphism. So the genetic variation can cause immunological susceptibility and vulnerability to invasive fungal infections. So, for example, if there is a deficiency of pentraxins in the person, that can cause invasive aspergillosis. If the person's CD50 is down regulations, it can cause trichocontis. Then if there is a polymorphism of CX3CR1 gene, it can cause an infection in the gut. And there is something called as mannose binding lectin. So it can cause PCP. Some patients are not has a lesser quantity of it. So that can cause PCP and RVBC. And TLR1 mutation can cause candidemia and NOD2, that is nucleotide binding oligomerization domain containing 2. If there is a polymorphism that happened, it can also cause invasive fungal infection. So the key takeaway is application of pharmacokinetic and pharmacodynamic principles to antifungal drug therapies, and to understand the relationship between the drug exposure and the patient. Polyene antifungal are still the first line treatment for most of the IFIs. The azole drug class is the most extensively studied class of antifungal. And only flucytosine and fluconazole achieve reliable tolerability for concentration and for treatment of lower UTIs. In case of intraocular or CNS infection, fluconazole, voriconazole, flucytosine, and liposomal amphotericin B would be optimal. And in case of so still studies are going on for combination therapy. So I hope that we get better combinations with lower resistance and lesser toxicities. These are some of the references you can go through. That's it. Thank you. Any questions?
Thank you, Dr. Alia. Your presentation was very informative and we appreciate your expertise. Okay, we can now open the floor for questions or comments from the audience. So can I go ahead with the questions?
Yeah, sure.
So first question is difference between conventional liposomal and emulsion amphotericin B.
So the main difference is the amount of nephrotoxicity. So conventional is the first amphotericin B that has come into picture, but due to its high nephrotoxicity, they had to come up with other formulations like liposomal amphotericin B and emulsion form. Liposomal amphotericin B, the amphotericin B is between lipid molecules, and emulsions are the two polypeptides. In between that, one amphotericin B molecule will be there. So emulsions has the least nephrotoxic. That is the main difference in this thing.
So our next question is which antifungal has lesser renal toxicity?
Echinocandins mainly has lesser toxicity, as explained. It does not attack our cholesterol or cholesterol. It directly goes for beta D glucans, and also some of the azoles like fluconazole and voriconazole does not cause any renal toxicity.
Okay. So
Again, it
I think
depends on which patient, which drug, and all.
Okay, thank you.
Sure.
So I think that is the end of the questions. If you have any questions related to today's topic or presentation, please send mail to our mail ID. Next slide, please. So I'm excited to introduce our next topic of the basic module, that is pharmacokinetics and pharmacodynamics of antibiotics, and the speaker is Saiba Lugando. So you can follow us on social media for the further updates. Before concluding, I will just go through the upcoming events once more. FCPA is organizing a virtual panel discussion on topic everything you need to know about BPS pharmacy certification on 25th September from 7 p.m. to 8 p.m. Indian Standard Time in collaboration with Board of Pharmacy Specialities. Second is the CP Conclave 2023 organized by Amida School of Pharmacy on 15th and 16th of November. CP Summit 2023 organized by the Indian Pharmaceutical Association Students Forum on 25th and 26th of November in Pune. RD Congress 2024 organized by ICRA Hospital, Calicut from 19th to 21st of January. So that's all for today's session. Thank you once again, Dr. Alia, for the presentation. Thank you, everyone.
Thank you so much.
Follow our social media platform for more updates.